So good afternoon. So welcome everyone for today's endocrinology grand rounds. So due to some logistics issues, I'm going to be the one talking today. So I will be talking about cardiometabolic risk in older adults with type 1 diabetes. I do not have any conflicts pertaining to this particular talk. I'll just go over briefly about type 1 diabetes in older adults in terms of what we know about it in terms of prevalence and things like that, and cardiovascular disease mechanisms, its relation to glycemia, and also prevention. And this is a increasingly relevant topic because of the number of individuals who have this particular problem. So this is one of the recent articles from JAMA, which had talked about the prevalence of type 1 diabetes in US children and adults by age, sex, ethnicity. So the first one here is younger adults, younger than 18 years of age. This is something that more people are aware of, and this is based on the National Health Interview that was published. So the next one here is the prevalence in among adults aged 18 years or older. So what you can see here, I have difficulty seeing it here. So one of the things that you see out of a total of, I think I can see here, that's not that clear. So you have a significant number of patients who are between 45 and 64 and more than 65. So they have a large number of proportion of adults with type 1 diabetes who are older, and that is a large population. And this is the worldwide data, which was published in Diabetology, looking at all over the world as of all the patients with type 1 diabetes, how many of them are 0 to 14 years of age, 15 to 39, 40 to 64, and over 65. And then they divided it by, high income countries, upper middle income, lower middle income, and low income. And you see here, not a whole lot of difference, but there are some differences in terms of the prevalence of type 1 diabetes. But you see again that more than 50% are above 40. And you also see that a significant portion of them are above 65. So you have a large number of individuals with type 1 diabetes who are 65 years and older. So this again is a slide that is looking at the epidemiology of type 1 in older adults. And mainly the reason I put this up, again, there's a lot of data here, but you may not be able to see it clearly. It is that it is from different countries, and one of the reasons there's a wide variance on how many are considered in this age group, and that is related to how they were diagnosed, what were the criteria that they used for classifying someone as having type 1 diabetes, and also what was the age cutoff that they used. And many of the studies do not have a actual measurement. It's a self-reported thing as to whether they would say they had type 1 diabetes or type 2 diabetes. And some studies are more detailed. So in some countries where they have national registry and they have data that is more that can be used to actually classify, you can get a better picture of what's the prevalence of type 1 diabetes in older adults. So one such thing is this from Australia. So what you can see here is that of all the individuals with type 1 diabetes, you have 0 to 20 years was 11.1%, and 21 to 39 is about 25.7%, 40 to 59 is 29.8%, and 33% are 60 years or older. So you have, by this one, 60 and older, you will get a third of the people with type 1 diabetes are in that age group. It's not that it's not the age of onset, it is they are at that age.
They LADA and all.
They are not subclassified as LADA or anything. There are some papers that have tried to look at those things. Again, for that reason, the exact incidence or prevalence of type 1 diabetes in the older population is actually not known because, as I said, it's self-reported, or even if you go and look at the charts, it depends on when they were diagnosed, and especially if they are 60 or older, many of these individuals, if they were young and had diabetes, they would be classified as type 1, even though they could have been type 2. And if you look at it, 40 years ago or even 30 plus years ago, there were not a whole lot of oral medications or other medications. So they would go on insulin. So they would be on insulin. I'm on insulin since I was diagnosed. So they say, okay, type 1, So that is an issue, which they highlight here, But overall, as we know, there is an increasing population of older adults with type 1 diabetes, and that goes along with the increasing population of older adults in general. So there's a higher proportion of elderly individuals worldwide. And so that's part of the problem in our trying to figure out exactly how much there is. And as I said, it varies across the world. So the other thing is that because type 2 diabetes is so prevalent, small differences make it, it gets blown up in terms of percentages, as to how many people have this. So the survival of type 1 diabetes certainly has increased a lot, but still, older adults with type 1 diabetes have substantially reduced life expectancy. And one of the things is related to the fact that a lot of the complications, including cardiovascular disease, is dependent on the lifetime exposure to hyperglycemia. So the longer they are exposed, the more likely that they're going to have complications, more likely that they'll have, and poor outcomes. So as I said, they have used most of the classification. Even the best studies have used GAD and C-peptide for classifying them. So that is, by current criteria, that would not be enough. You would have to do more antibodies to be able to classify them properly. And even to this day, there is no gold standard. We often see where we classify somebody as type 2, and maybe down the road we change that diagnosis that they become positive. So that is an issue that has been there. Now, there's an alternative way to look at it, which is look at Medicare. How much Medicare data has been collected. After all, they're the ones paying for a lot of the care of these individuals. So this is a study that looked at the medical costs associated with diabetes complications in Medicare beneficiaries 65 years or older with type 1 diabetes. So obviously in this one of the problems is that the diagnosis of type 1 diabetes is based on whoever submitted the thing saying that somebody has type 1 diabetes. That's how I'm going to bill it. But what you can see here is that in this, so this is from 2017. So this is 2016, 6 to 2017. So there were 114,879 individuals they looked at, and you can see their mean age at 76.9, which is pretty good. There were more female than male in this population. Non-Hispanic whites, 77%, Hispanics 7.13, non-Hispanic black was 11. It's very close to the overall population as such. And then 50% of them had no complications. And then you had one complication, about 28.5, about 30%, and then you have about 12% with two complications, 5.13 with three complications, and with more than four complications was about 3%. So looks like the majority had either no complications or one complication related to type 1 diabetes. This is the overall thing where you're looking at what is the major drivers of this cost of type 1 diabetes. And this one here is the estimated cost itself in terms of dollars. And what we find here is there are some high things where nephropathy, this is per person per year cost. So this is about $10,200 for nephropathy. And then, of course, if somebody is on dialysis, it's about $55,000 per year per person. And then if they've had a transplant, it's about $77,800. And then the other ones that are expensive. I mean, renal disease is certainly one of the major factors. The next one is going to be lower extremity amputation as a huge cost. And then you have macrovascular disease, congestive heart failure, myocardial infarction, revascularization, stroke. So these are the things. And I can see that, renovascular disease, cardiovascular disease, these are the major drivers of this. Overall, in this population, they have about $1 billion a year is what the cost of in the Medicare population, older adults with type 1 diabetes. So that was in 2017. So in general, it seems like there is a significant number of individuals with this particular problem. So why does this happen? So there are certain things about cardiovascular disease and type 1 diabetes that are common to other cardiovascular risks, and there are some which are unique to type 1 diabetes. There are the usual risk factors: endothelial dysfunction, oxidative stress, inflammation, lipids, things like that. And then you have long-term hyperglycemia, which both depending upon the severity and duration of hyperglycemia. The other factor is the presence of diabetic nephropathy. Then you have cardiac autonomic neuropathy, particularly related to cardiac arrhythmias, and also it is related to cardiovascular mortality in the cardiac arrhythmias. Hypoglycemia is another factor, and I'll discuss a bit more about hypoglycemia in type 1 diabetes as a risk factor for developing cardiovascular disease. Then there is the issue of glycemic variability, so which is increasingly being recognized. And one of the things that was noted, as you all know, the landmark study for type 1 diabetes is the Diabetes Control and Complications Trial. In that study, that's what established A1C guidelines and the importance of glycemic control. But there was one thing that was noted, which was that although A1C predicted complications, it was not, it was not 100%. I mean, there was a significant variance. So one of the things that was noted was that people who were having more fluctuations in blood sugar had higher rates of complications. Of course, in the days, the DCCT was done somewhere between 86 and 92 or 93. So in that period, It was finger stick blood sugars, and they did before each meal. And then they had also, for 1 week each month, they would do a 7-point blood sugar check, before and after each meal and at midnight. So they had some more data, so they could get some idea of variability. So people have analyzed variability. Variability is difficult to figure out because there are a number of statistical methods by which you can define what you mean by glycemic variability. Is it the amplitude of variation? Is it just standard deviation? Is it severe high, severe low? So there are questions about what is the best method, the best indicator of variability. So there are more recent studies that look at variability because we now have CGMs. So that way we can get a better handle of how much of variation there is. Then you have insulin resistance in obese type 1 diabetic patients. That is also an important thing. As we know, insulin resistance, particularly in the obese individuals and in type 2s, is linked to cardiovascular disease. So older adults with type 1 diabetes and who are obese or insulin resistant, they also would have a higher risk. And there are some other hidden risks. And there is also a question about cardiac autoimmunity. And one of the things is that type 1 diabetes is an autoimmune disorder. And there is some data to show that cardiovascular disease is more common in a lot of autoimmune disorders. So and I have a slide that looked at it from the point of view of type 1, because whether it is lupus or rheumatoid arthritis or even hypothyroidism, and a number of these autoimmune disorders have higher rates of cardiovascular disease. And so there's some question that autoimmunity itself will do that. So one of the drivers, of course, is hyperglycemia, which can, there's multiple pathways by which it can increase it. One of them is the increase in PKC, which then increases inflammation. And then you have the polyol pathway and increase in oxidative stress, and then advanced glycation end products, which also leads to increased cardiovascular disease through multiple mechanisms. So when you just look at it overall, you see here that cardiovascular disease morbidity versus the control population is increased about 2.4-fold to 3.6-fold in men and 3 to 7.7-fold in women. When you look at mortality, again, 2.6 to 8.8-fold increase in men and 2.7 to 24.7 increase in women. And the earlier onset, means severity means the earlier the onset of type 1 diabetes, the greater it's going to be. That means if you have had type 1 diabetes onset less than 10 years versus onset more than 26 years, you will see that the individuals who develop type 1 diabetes early had a greater risk of developing heart disease. And that was related likely to the duration of exposure to hyperglycemia. So, and it is true for both the morbidity and mortality. And of course, this here talks about this, and we'll touch on some of these. It's difficult to go through all of these different factors that are involved in cardiovascular disease and type 1 diabetes. So a lot of the data, because initially people didn't pay much attention to heart disease and type 1 diabetes because, more interested in cardiovascular and microvascular complications, and also the life expectancy was not that long. And then, of course, with type 2 diabetes, we have been recognizing it more. So there are some common pathways, but there are also some differences. So this is a study that looked at the, 2 different types of diabetes to see what are the things that are common, and in what way is it different? So both type 1 and type 2 diabetes, have been increasing, and they have higher rates of other cardiometabolic risk factors. So one of the things that we look at in type 1 diabetes is not only type 1 diabetes as by itself, but also the fact that other cardiometabolic risk factors, which are highly prevalent in type 2 diabetes, are also more common. And the other thing is that a lot of the times the ability to, even in our clinic population, if you look at it, a lot, we'll see more type 2s who we address cardiovascular risk factors and can get it under control than type 1s. More often than not, you're more focused on their glycemia, and other aspects are not as aggressively addressed as we would like to. And of course, comparisons are difficult because the populations are difficult, the age at onset, their weight, their underlying comorbidities are different. So it is true, though, that to be able to reduce the cardiovascular disease, you need to get a long-term achieve control, both for glycemia and also for other cardiovascular risk factors. So this one here is simply looking at, this is those who have type 1 diabetes or those who don't have, and what you find here is, you see that there is a significant increase, so one of the things that you have, this is the hazard ratio. So it's a relative risk that you're looking at. And again, the females, it's higher mainly because their control population has a lower rate. So that's why it looks more. Then you look at all these things that, that age, and then you have smoking status, and then you have BMI, and then blood pressure. So these are the things, and this is for coronary artery disease and also for ischemic stroke. So certainly having diabetes, significantly increases no matter what the other cardiovascular risk factors that you have. So this one here looks at according to the age with type 1 diabetes was diagnosed. And you can see here that in all of these things, you find that the younger the age that they were diagnosed with type 1 diabetes, the higher was all-cause mortality, cardiovascular mortality, non-cardiovascular, certainly with cardiovascular disease, coronary artery disease, MI, stroke, heart failure. So they were all much higher in individuals who developed type 1 diabetes at a younger age compared to those who developed it later. And this is just showing us one thing, which is that, when you look, however, at the type 1 versus type 2, the survival, again, the thing about type 2 is that the type 2s have a higher mortality, and that is more related to their associated conditions. So they tend to have a higher mortality. So the survival is particularly, depending on duration of disease, that it'll be higher for type 2 than for type 1. And there are also some issues of gender differences in cardiovascular risk estimation. So here, what we see here is this is the 10-year CVD risk score category. So one way to estimate cardiovascular risk in type 1 diabetes is the steno risk score. This was developed in Steno in Sweden, I think Sweden, where they have a full registry of type 1 diabetes, and so they developed a score. So there's a score by which you can go. And this looks at the percentage of individuals who have low CVD risk score, medium CVD risk score, and a high CVD risk score. This is men and women, and this is by 10-year CVD risk score. This is by age, and I can see here that older individuals have a higher rate. And then this one here is that with less than 55 years versus more than 55 years. So one of the things that you see here, male versus female, is that you will find that difference is not there after the age of 55 as compared to in the younger women. So this one here is looking at the same things, looking in carotid atherosclerosis with comparing steno with medium versus low scale and high versus low scale. Again, you see that there is an increased risk. This is for presence of diabetic neuropathy or diabetic retinopathy. So one of the things that we know from this and other type 1 diabetes studies, including DCCT, is that the presence of microvascular disease increases the risk of macrovascular disease. That means morbidity and mortality is higher in type 1 diabetics who also have microvascular complications. So that is something that we have to keep in mind. So this is to summarize the particular study, looking that, this was a multi-center study, 2,041 patients with type 1 diabetes, 44.9% women. So they used type 1 risk engine to estimate 10-year score. So the CVD prevalence higher in men than in women aged more than 55 years, but comparable between two sexes, those less than 55 years. So the mean 10-year estimated CVD risk was 15 plus or minus 0. Without any significant sex difference. So stratifying by age, the 10-year estimated risk was higher in men than in women until age 55. But this risk equalized after this age. Carotid plaque burden was significantly associated with age greater than 55, with a medium and high 10-year CVD risk score, without any significant gender difference. So diabetic retinopathy, sensory motor neuropathy were also associated with higher 10-year risk and female gender. So for both men and women with type 1 are at high risk of CVD. The 10-year risk in men is less than 55, but was higher than in women. But then, as I said, after the 55-year age group, there was no difference between men and women in terms of their risk. So of all the things, I mean, I only picked a few topics to talk about these risk factors, for which the data was new. And one of them is the issue of metabolism associated steatotic liver disease. What we used to call NAFLD, now we call it as MASLD. So we often link this to type 2 diabetes and obesity, but this one here looks at what about type 1 diabetes? What happens to type 1 diabetes? So this is a study that looked at 500 participants with type 1 diabetes. Of course, this was done recently, so they had CGM data. They also did glucagon and C-peptide measurements to classify them better. They did transient elastography to, look at fibrosis, cystiatosis, and fibrosis, and then, predictors. Try to find out what are the things that predict fibrosis and things. So this is the thing. Started with 500 people. They had 450 were included, 460, and then they had 7 were excluded for misclassification, missing data. So this one here shows us about some of the things we're looking at. Steatosis. This is not a fibrosis score, but steatosis, the equal number of individuals. And you can see here that, one of the things was age was a factor. So the higher age, there was more steatosis. And then you had BMI. So the higher the BMI, the more likely that they would have steatosis. And then you had duration of diabetes. You can see here that individuals with more steatosis had type 1 diabetes for about 23 years on average. And then glycemic control, time in range, time above range. So you can see that the time in range was less, time above range was higher. So these glycemic parameters were matching with this on the time in range. So you can also see the A1C was higher. These are in millimoles per liter. So there were certainly several of the factors, such as glycemia and time in, and also microalbumin. They were all related. The presence of retinopathy, what percentage of patients had retinopathy was also important for the amount of steatosis. So there was an association between complications, glycemia, and steatosis. So they had a very complicated statistical method. It is called extra trees feature importance. It's kind of a AI-derived method by which they can predict certain complications based on some of the factors that we have. And then this one here talks about this is for duration, age, systolic blood pressure, BMI. These are the different things that are related to future prevalence of either, this is for steatosis and the other one is for fibrosis. So you have different ways, different factors that may play a role in the development of these. And this is the fibrosis scores. And again, what you find here is, we found that there's a lot of correlation with steatosis, but with fibrosis, there are very few things. One, of course, has to do with BMI. And then you have duration of diabetes as a factor. The longer the duration of diabetes, the more fibrosis. But when you look at time in range and A1C and things like that, there's not much of a difference. So the glycemic factors and they correlated more with steatosis than with fibrosis. So their main thing was that metabolic dysfunction associated steatotic liver disease is associated with high prevalence of hepatic fibrosis. How this happens, we don't know. It's also high prevalence of cardiovascular disease, and it shows that microvascular complications, high blood pressure, and type 1 diabetes. So as I said, this was more so with the steatosis score than with the fibrosis scores that you have. Since we now consider, metabolism associated steatotic liver disease as a cardiovascular risk factor or contributing to that, this is something that we have to keep in mind, and maybe down the road that'll have more data. But this is relatively new. We are not doing, assessments for all our patients with type 1 diabetes for looking for fatty liver disease. So this is the other thing that I had mentioned about, that there is some data that autoimmune disease and cardiovascular disease, so they looked at 19 different autoimmune diseases and 12 cardiovascular disease in 22 million individuals in the UK. So what they found here is that, people who have autoimmune disease tend to have more cardiovascular disease. So they have, several of these disorders where you have, type 1 diabetes, you can see here the odds. The hazard ratio is 2.36, and then you have a number of other disorders that we have, that also have higher rates of cardiovascular disease if they have autoimmune disorders. And it is not entirely clear why that happens, but that is something that is being looked at. So one other thing that is of importance in type 1 diabetes is about the issue of hypoglycemia. So, we are, from the DCCT data, we had a lot of things talking about severe hypoglycemia as a risk factor for cardiovascular death, and which again, cardiac arrhythmias and things like that. So this study looked at the factors that, why, what are the associated things? Because when you look at the raw data, what you find is that it's not so straightforward. There are a lot of people who have a lot of hypoglycemia, but they don't have any cardiovascular disease. So they're looking at what are the determinants. Again, this is the DCCT study. This is the, I think, the 30-year follow-up or something in that time frame. So they looked at association between any severe hypoglycemia and ischemic heart disease, and their interaction with micro and macrovascular damage, and that was what they looked at. So this is the thing that shows you what the thing is, and what you find here is that, so the p-value for the association between severe hypoglycemia with ischemic heart disease, per year increments to 15 years. So you can see here, as the duration is higher, the longer that you have had type 1 diabetes, there is a greater association between severe hypoglycemia and ischemic heart disease. The other thing that they also noticed was that, they have a diabetic retinopathy score that was done in all the patients with DCCT, because that was one of the key things. So again, what you find is that the higher the ETDRS, the diabetic retinopathy score, the more likely that they would have severe hypoglycemia and IHD were associated with each other. Then there is this thing called DCSI. DCSI stands for Diabetes Complication Severity Index. Okay, so that includes several complications of diabetes. So you add up, there's a score that you get, and it tells us, so the higher the score, that means higher score means you have more complications. So the more complications you have, the more association that you will have. So, so one of the things that they found here was that those three were the ones that were, both in the basic and extended model, that they were found to be related, whereas just, the CV risk score was not the one that was related to the severe hypoglycemia and ischemic heart events. So, and the reason why we highlight this is because while it is important to address the cardiovascular risk factors, the traditional ones that we do for anyone with high risk, type 2 diabetics and all this, addressing microvascular complications is key to preventing cardiovascular disease in type 1 diabetes. That means that if you have more retinopathy, if you have higher blood sugar, higher variability, all of those things will increase the risk of disease and also the risk of ischemic heart events. So in a young cohort with type 1 with no baseline macrovascular complication, surrogates of baseline microvascular damage severity impact the effect of severe hypoglycemia on ischemic heart disease. Older age with high CV score per se is not mandatory for an association with severe hypoglycemia and IHD, and it's multifactorial. So this is something that we have to keep in mind, and again points to trying to avoid hypoglycemia in patients with type 1 diabetes. Again, here, this is a study that was recently published in JCNM. looking at coronary artery calcium scores in individuals with type 1 diabetes, and looking at what we call A1C variability. So we often see patients in our clinic, several times a year. We get their A1Cs, and they go up and down, So I talked about glycemic variability, where you're looking at a CGM where it's a daily up and down. But individuals who they come in, this time they have an A1C of 6.8, next time they're 9.2, then they come back and they have 7. So this variability in the A1C, the A1C variability metrics, they also predict coronary artery calcium scores and cardiovascular events in type 1 diabetes. That means that not only is it important to control the blood sugar, but to keep it under control, for a long period of time, that you don't want fluctuations, not only on a day-to-day basis, but on a month-to-month. Or it means, this month I'll do well, and next month I want to, cruise, and I really don't care. So, so that's why, irrespective of baseline A1C, mean A1C, time varying A1C, even after adjustment for numerous cardiovascular risk factors, this was important. So A1C variability is another factor that we have to keep in mind. So as I said, it's difficult to compare type 1 versus type 2, but when you look at some of the outcomes, this is a UK Biobank study, which was published very recently. And you can see here that things such as, for A1C, the higher the A1C, the composite cardiorenal outcomes are, the curve is steeper for type 1 diabetes than for type 2 diabetes. Same thing with atherosclerotic vascular disease. You can see that it's higher for chronic kidney disease. For heart failure and all-cause death, it's not so much different, but for these, there is a significant difference in the sense that for, if you're looking at composite cardiorenal outcomes and atherosclerotic cardiovascular disease, the A1C control is something that is important. And you also notice here, this one here, compares type 1 versus type 2, and you find here that, type 1s actually have worse outcomes for both composite cardiovascular and atherosclerotic vascular disease. So that's why it's important to address cardiovascular disease. So in this population, this is a cohort study. Type 1 diabetes, higher risk of cardiorenal events or death compared to type 2, despite younger age and greater baseline risk factor control. Risk factor control was limited in both type 1 and type 2. Worse glycemic control was more steeply associated with cardiorenal events, as I showed you there. So the importance of targeting comprehensive risk factor control across lifespan, especially in type 1 diabetes. And of course, newer methods of intervention is something that would be important. So this again, the UK Biobank looking at the presence of microvascular complications and diabetes-related macrovascular complications. So again, what this study shows also is that more microvascular disease you have, the more macrovascular disease that you will see. So these are the curves. It may be difficult for you to see these curves looking at multiple different outcomes. And what we find here is that it's a follow-up of 11.61 years. So you have participant primary outcome in type 1 and type 2 diabetes, respectively. If you adjust for everything, what you find is that the primary outcome, except for coronary heart disease in type 1 diabetes, you'll find that there is a higher risk. So individual and cumulative macrovascular disease confer significant risk of incident microvascular disease complications in type 1 and type 2 diabetes. So high-risk population, you have to address both of those things. So this is a review that was published earlier this year in the New England Journal, looking at prevention of cardiovascular disease in type 1 diabetes. For the fellows, this is this is an excellent review that addresses these things, looking at, the traditional ones: hyperglycemia, hypercoagulability, hypertension, weight, physical activity, and these others, which are kind of surrogate markers. So this is the weight chart that they have in patients with type 1 diabetes in the type 1 diabetes exchange cohort. And you can see depending on the age. So you will find that in the younger age group, you have 24% who are overweight, 17% obese. But by the time you come to 26 to 49, you have the majority, about 60 to 70%, are either overweight or obese. So they have a significant problem there. So that is something that needs to be addressed. These are the recommendations for lipid lowering. And one of the problems, and there are a couple of letters addressing this thing, is that there are different societies that have given different guidelines. So the ADA and the American College of Cardiology, AHA, European Society of Cardiology, International Society for Pediatric Adults and Diabetes, they came up with some, they're in some ways similar, but there are differences. And there is some attempt to make it more uniform as to what the guidelines should be and what targets should be. So for 40 to 75 without, so in general, some of these in the older population is very similar to what we do for type 2 diabetes. The bigger issue is about the younger population, which is what the pediatric and also diabetes societies have addressed. Intervention for 6 months does not lower LDL. Statin should be considered in children greater than 10 years of age with an ideal LDL cholesterol less than 100. When you look at this, the other factors such as glycemic control, A1C less than 7, hypertension, antithrombotic therapy, and weight management. And one of the things here is that despite all of these, what you have is that when you look at what proportion of patients are getting any of these drugs, there's still a large gap of, in the type 1 population, you're only having about 25 to 30% getting statins or other lipid-lowering medications. And then, of course, slightly more are getting blood pressure medications. So that's one of the issues that needs to be addressed. And there is evidence that statin use in type 1 diabetes does prevent cardiovascular disease. So what you see here is that out of 931 patients type 1 diabetes, 8.5% suffered primary outcomes. Statin treatment reduced risk of the primary outcome, adjusted heart ratio of 0.76. Statin use led to decreased risk of ischemic stroke and myocardial infarction, but not related to hemorrhagic stroke. So the risk of cardiovascular disease events decreased as the cumulative exposure duration of statins increased. So it is strongly recommended to use statins in these individuals. So then there is the question of using SGLT2 inhibitors and GLP-1 analogs in patients with type 1 diabetes. So this is a more recent study that was done, or this is actually a real-world study that, although these may not be approved for use in type 1 diabetes, people are using it. And so there is data on looking at, these two agents. So either this is, 196,000 individuals with type 1 diabetes, and you have, adjunctive glucose lowering therapy. So they have there were 3,286 who had GLP-1 receptor agonists and 1,692 with SGLT2. And finally, of course, there were some exclusions. So you had a comparison of these two different drugs. And one of the things that you have, which, we would expect to see, is that, people who are using SGLT2 inhibitors had higher DKA and urinary tract infection. So in terms of safety, it was better with the GLP-1s. Although GLP-1 is not something that is approved for use in, but you can see that there's a significant number of individuals who are actually on this drug. So that is one of the things that you have. So one of the main issues of concern is the when you use SGLT2 inhibitor in type 1 diabetics, is about DKA. So how do we address that? And particularly because congestive heart failure, people with type 1 diabetes with congestive heart failure will get an SGLT2 inhibitor, not for glycemic control, but for their CHF. So, as I mentioned in the initial thing, in the Medicare population, a significant cost is CHF in patients with type 1 diabetes, as per person cost goes up when they have that. So the incidence of this has increased among patients. So the Scottish Diabetes Registry, there's a Swedish National Registry, 2 to 5 times the higher crude incidence of rate of heart failure hospitalization for men and women compared to those without diabetes. So there is a higher rate of CHF, and it is thought that it may be more common among men and women with type 1 diabetes than among type 2. So this is those who don't have ischemic heart disease. So
how did they bounce age into that study? In other words, I guess that were they all comparable ages, because
no,
they're not getting it till we are older.
They were adjusted for, they adjusted it for what they had.
Right, so they just
Correct. This is the registry, the National Diabetes Registry that they have in Sweden. So one of the first things is to recognize the CHF early. So their approach to this is to do early screening for individuals with type 1 diabetes and see if they can identify heart failure earlier than where we currently do, and see if interventions are going to help them. So this is the ADA came out with these things. A couple of years ago, this was published looking at these 3 different stages, of heart failure in patients with type 1 diabetes. This one did not specifically say type 1 or type 2. It included both type 1 and type 2 diabetes. And then, to look at different interventions at using a multidisciplinary team for addressing heart failure in patients with type 2 diabetes. So this is the Swedish recommendation, or the Swiss recommendations on, if they have no signs or symptoms and they're more than 60 years of age, measure every year. They recommended measuring BNP. And if it's more than 300, heart failure likely is between. So they have a flow chart on trying to screen for heart failure in these individuals. And then, the recommendations in terms of interventions. So depending upon the stage at which they are. I'll skip this. And the issue of diabetic ketoacidosis, which occurs in the use of SGLT2 inhibitors, which is related to a decrease in insulin secretion, an increase in glucagon secretion, and then, decrease excretion of ketones, glucosuria with volume depletion leading to ketosis. So, you use this protocol called the Stop DKA protocol. So this is the initial recommendations starting in individuals with type 1 diabetes. So, these are the recommendations in terms of making sure that patients are aware that they could test for ketones, because typically we're only, for a typical type 1 diabetes, we're only asking them to check for ketones. The blood sugar is very high, but when you're on an SGLT2 inhibitor, you have, if you have any symptoms that are suggestive of ketoacidosis, that you have to do that. So that's why, recognize symptoms of DKA, avoid very low carbohydrate and ketogenic diets, avoid excess alcohol, extreme exercise, stop SGLT2 inhibitors 3 days before major surgery, and don't stop taking insulin. And then the sick day management. And then these are the recommendations in terms of how to address it when you check it. So these are protocols that can be handed out to the patient so that they can use it for prevention of DKA. And then this was a very interesting study that there is the continuous ketone monitoring. So the Diabetes Technology Society had a consensus conference, and they came out with some recommendations on the potential for, because increasingly we're using, CGM and pumps, so with the closed loop pumps, so now the patient doesn't know what all is happening, they're letting the pump do it. And the idea here is, can we link the pump with a continuous ketone monitor so that it can address the issue if the ketones go up, that will adjust the insulin dose. So it is possible, but at this point, we don't have that technology yet. In fact, correct. So for Abbott has a CKM, it's not approved, but they have done studies on this. But that is, I think that is still not pump linked. It is still, it gives you the readings, So they've done studies with the, with the CKM, the continuous ketone monitor, but, we don't know. So this is their thing, that if you're going to start somebody on an SGLT2 inhibitor because of CHF or renal disease in type 1 diabetes, to educate them, monitoring, recognizing symptoms, use the Stop DKA protocol, and of course, the issue of continuous ketone monitoring, maybe something down the road. So just to summarize it, it's a significant problem. Prevention efforts should start early and address multiple risk factors. Early detection would help improve long-term outcomes, and addressing weight, use of SGLT2 inhibitors and GLP-1 analogs. In terms of GLP-1 analogs, we do not have cardiovascular outcome data in type 1 diabetes. It's just that because they can lose weight, the weight loss is less in the small studies that have been done compared to others. And of course, in general, type 2s also lose less weight than non-diabetics, with the same medication. So those are the things. This is the event code. We'll be happy to answer any questions. I know. I'm also quite, I rarely use it. I have this patient who, keeps asking that. I don't know why his primary care is so much bent on starting him on an SGLT2 inhibitor. I keep looking. He's actually a islet transplant patient. And I said, it's not going to help. He's on a pump. He's got CGM. I don't think. No, he's not type 1, but he's,
So you don't.
yeah, he has. But the thing is that he still can go into DKA. The problem is that he keeps asking about. I said, what do you want to do? I mean, it's not like if I add an SGLT2, I can get better glycemic outcomes. It's still going to. The problem for him is the variability. I'm not going to smoothen it out. But they want to do it. And I said, but if he goes into DKA or gets dehydrated, it's more complicated. He has had a pancreatectomy, so don't want to do it, but somehow he keeps asking it, So. Correct. I mean, if they have gastroparesis, wouldn't use a GLP-1 analog, but for weight loss, you can use it. There is not much of a problem. It is not, I mean, getting it approved may be a problem, but otherwise, you can use the GLP-1 analog or type 1 diabetes, obesity.
I don't think that they, in the American Heart calculator for risk, I don't think they differentiate between what kind of diabetes you have.
Correct.
Although on the other hand, you wonder how many type 1 diabetics they may have had in those studies. And I don't know that I ever heard that correct.
No, I mean, the Steno type 1 diabetes risk score is more specific for type 1 diabetes. The CBD risk score that they have, but so there are a couple of questions here. Cardiometabolic risk in older adults. Are there differences in type 1 diabetes and type 2, or is type 1 treated only with metered insulin as a Ozempic treatment? So as we were talking, as far as the GLP-1 analogs are concerned, it's only for weight. We don't have data on cardiovascular outcomes for type 1 diabetes. So it is not used for treating blood sugar in type 1 diabetes. There are some studies that are ongoing, so we'll see what it will be. But otherwise, type 1 diabetes is treated mainly with insulin. Dr. Winsor had a question about the cholesterol targets for type 1 diabetes. For the adults, it is the same, but for the younger population, they have, again, because different societies have different guidelines, and there are very few that have that are that clear. Less than 100 is what is in terms of LDL target is what has been recommended. Some others use less than 130. So there is some variation on that. Because there are no studies that would link what the LDL cholesterol intervention was at the younger age and what happened later, I think it'd be difficult to, at least at this point, come up with a clear-cut, evidence-based guideline. It'll just be, some sort of a